morning, everyone, and welcome to today's webinar, Public Health Nursing Care Plans for Supporting Perinatal Mental Health Practice and Home Visitation Programs. My name is Andrea Bodkin, and I am a Senior Program Specialist at Public Health Ontario, and I am excited to be co-moderating today's session. I'd like to acknowledge that today I am coming to you from Treaty 13, the lands associated with the Toronto Purchase of 1805. And these lands have been the historical and ancestral lands of many First Nations for thousands of years. People who lived, hunted, traded, traveled, learned, and prospered on this land. These First Nations include the Haudenosaunee, the Huron-Wendat, and most recently the Mississaugas of the Credit, who now live in and around Hagersville in southwestern Ontario. I recognize that as a settler whose ancestors settled in southwestern Ontario in the 1800s, the privileges that I hold today are a direct result of their actions. I am so happy to introduce my co-moderator for today, Dr. Susan Jack. Dr. Jack is a professor in the School of Nursing at McMaster University, and she is a recognized leader in public health nursing. Her work centers on developing and evaluating interventions aimed at improving maternal, infant, and family health outcomes. As the head of the Public Health Nursing Practice Research and Education Program, she is dedicated to advancing both public health nursing practice and education. Sue, thanks so much for being here today for the webinar.
Good morning, everyone, and thank you very much, Andrea. We are so grateful for the partnership that we have with Public Health Ontario that allows us to provide these webinars to public health teams across the province. And I'm really excited to be here today. For those of you who joined us last month, I believe that I shared that this year's series of webinars are all focused on perinatal mental health. We have consistently heard that that is a professional development need for nurses and supervisors across the province. And so we are very committed this year to not only providing webinars and speakers to increase your knowledge about perinatal mental health issues, but have also been working very hard to develop resources to support nurses increase their skills and confidence in recognizing and responding to perinatal mental health concerns in your home visiting and group work practices. So today, on behalf of myself and PHN Prep, as well as the Provincial Perinatal Mental Health Working Group that we established, I'm really excited to introduce our two speakers for today's webinar. And our first speaker will be Bonnie King. And Bonnie King has been a registered nurse and an educator and a consultant with over 30 years of experience in public health in a variety of leadership roles. And in 1997, when I moved to Ontario from Alberta, she was actually the first nurse home visiting manager that I met and had the opportunity to sit and reflect with on what are some of the challenges and strengths of home visiting practice. And about 10 months ago, Bonnie retired from public health, but I'm really excited to announce that Bonnie is now the interim director. She's back at work. She's now the interim director for the Healthy Families Division and the chief nursing officer at Hamilton Public Health. So wonderful that she is returning to share her expertise. And our second speaker today is going to be Christina Bradley. And many of you, if you don't know Christina already, would have met her last month again. She was a really key speaker on our panel presentation last month. And Christina is a registered nurse, lactation consultant, and a public health nurse with Niagara Region Public Health and Emergency Services. She has over 25 years of experience, and in that time has really developed some, I would say, advanced expertise in perinatal mental health, family health, and health promotion. And for almost the last 10 years, Christina has been one of the public health nurses across the province that has been specially trained to facilitate steps, the program called Steps to Wellness before and after baby, which is a group that uses CBT strategies to support individuals who have postpartum depression. So both Christina and Bonnie are members of the provincial working group that we have established, and Christina has served as the co-chair. And this working group was established to develop public health nursing care plans and to provide detailed guidance on how to recognize, assess, and respond to a whole range of perinatal mental health concerns among individuals who are enrolled in the Healthy Babies, Healthy Children program. And today's webinar is going to be the launch and the introduction to this work. So it's my pleasure to welcome Bonnie and Christina. So over to you, Bonnie.
Good morning, and thank you for the introduction, Susan. I'm really happy to be here on behalf of the Advancing Public Health Nursing Practice to Address Mental Health Working Group. That's a mouthful of a title, so from here on in, I'm going to just refer to it as the working group. But we're really happy to be here today to share the work that's been done over the past roughly year and a half, and to walk through the care plans and the plans for the work that's coming down the pipe. So I'm just going to flip the slide here. So there are 4 webinar objectives for today. We're hoping to provide a fairly detailed overview of the process that we went through in developing the mental health nursing care plans, as well as the practice guidance document that will accompany the care plans. We want to share the overarching framework that was developed to guide public health nursing practice, particularly with respect to perinatal anxiety, depression, self-harm, and psychoses. We'll talk about how the care plans support nursing care in the home visiting programs, and how they will guide practice from early identification through to evaluation when nurses are responding to mental health concerns in the perinatal period. And we'll also talk about the alignment between the perinatal mental health nursing care plans, as well as the evidence-based tools and interventions that are available for use by nurses within home visiting. Okay, so we all are very familiar with the issue of mental health in our clients and families that we serve, and we know that during the perinatal period, it's often unreported and it may go untreated. I think it's really staggering to note that in Canada, almost 1/4 of birthing moms who recently gave birth reported feelings consistent with either postpartum depression or an anxiety disorder. And in addition to that, we know that paternal postpartum depression can occur up to 10% of men between the first trimester and up to 1 year postpartum. So it really is a significant issue that nurses are addressing. We also know that there are significant consequences if perinatal mental health concerns go unidentified and untreated. And I'm sure that you're all very familiar with these, but there can be significant negative impacts on parent-child attachment and relationships, on healthy growth and development, on the social and emotional development of infants and young children, on relationship stress, on family well-being, and certainly in extreme situations, there can be an impact on maternal suicide or infanticide or harm to others. Okay, so one of the exciting things is that home visiting nurses are in an amazing position to be able to recognize the signs, risk factors, as well as protective factors for perinatal mental health concerns. And that includes suicidal ideation. Nurses have an amazing opportunity to form a therapeutic nurse-client relationship and relationships with families and with visiting in the homes, have a really unique opportunity to ask about and to observe general mental health and well-being of a pregnant individual or postpartum person at every visit. And we know that many of the families that are enrolled in HBHC or the Nurse Family Partnership programs are either at high risk for or are actually experiencing poor mental health. And we know that for those families that are experiencing mental health concerns, they may not receive the maximum benefit of home visiting interventions because they may experience challenges focusing on attachment-based or other activities. They might be struggling to implement some of the positive parenting skills that nurses and family home visitors are working with them to build. And we certainly know that they have many barriers in accessing community programs and supports. So the PHN PrEP program, or I guess Susan's group et al., did a needs assessment, I believe it was in 2023, looking at the needs of nurses through interviews with both frontline staff and leaders around working with families with mental health concerns. And the report identified a critical need for professional development, for nursing practice and nursing practice tools, and resources that would improve public health nurses' confidence, knowledge, and skills to identify and be able to address and respond to the mental health concerns of the pregnant individuals and new parents that they were visiting. And while nurses described feeling confident and skilled in screening and being able to identify individuals and families at risk, particularly for depression and anxiety in the pre and postpartum period, and they felt confident being able to refer families to mental health services and engage primary care providers in treatment, the need was identified to support nurses to be able to offer a broader range of interventions that would support clients in managing the secondary symptoms of mental illness. So the process that we went through as a group, we established, I guess, the group in June of 2023 with representatives from public health units across the province. The first work that we did was identifying existing evidence-based work in relation to perinatal mental health that could be leveraged and adapted to support home visiting nurses. And we prioritized the development of a framework for the nursing care plans specific to perinatal mental health and started working on an accompanying guidance document in terms of what it needed to contain to support nurses in using the care plans. So this is the membership list of the working group. I'm not going to read everyone's name, but we are certainly grateful for the time and effort and support of everyone on this list. It's been an incredible process and some pretty amazing work has come out of it. So thank you to everyone that's listed as a member. We also want to say a really big thank you to Chatham-Kent Public Health Unit, Northwestern Health Unit, Ottawa Public Health, and Simcoe Muskoka District Health Unit. They were willing and volunteered to participate in a formal review of our draft documents, and they provided us with substantive feedback on the perinatal mental health resources that were developed in draft, as well as sharing some amazing recommendations for enhancement for training and strategies to advance practice in this area. So a big thank you to those 4 health units. We also want to acknowledge that the development of our evidence-informed resources was supported through reviewing and including or adapting the following resources on this list. These were the most significant and relevant resources that informed the work of the group. So evidence-based practices to address parental mental health in the perinatal period, which was an evidence synthesis. The PCMCH care pathways work, as well as their guidance documents, the Healthy Human Development Table Perinatal Mental Health Toolkit that's been developed, RNAO best practices guidelines for perinatal depression, and we had local perinatal mental health resources shared from 9 public health units that was incredibly helpful. We also want to acknowledge and thank the Niagara Regional Public Health and Emergency Services for providing permission to adapt and use the 4 listed care pathways below and resources. That saved us a huge amount of time that we had something that we were able to use and modify and adapt for nurses across the province. So a big thank you to Niagara. Okay, and I'm going to turn it over to Christina, who's going to walk us through the framework for the nursing care plans.
Thank you, everyone, and welcome. Thank you for joining us today. I am so excited to share with you a little sneak peek of, all of this work that the working group has been doing for well over a year now. So the Provincial Council for Maternal and Child Health, so PMCH, drafted a perinatal mental health framework. And within that framework, and this framework went out to healthcare providers across the province, within this framework, it recommends that healthcare services connect clients with Healthy Babies, Healthy Children's programs within their community, which is great, which is fantastic, right? Like our home visiting nurses, whether it's within the Nurse Family Partnership or HBHC, are in this really unique position to be able to support clients in reaching their parenting goals, but also recognize that they might have some perinatal mental health challenges. So again, fantastic that we're being recommended as, a support and resource for these families. But what does that then look like? What does that look like within the home visiting context? So this is where the framework that was kind of created by this working group provides that overview of exactly what it might look like. So it's this high-level graphic illustration of nursing practice in perinatal mental health. So following that nursing process, starting with that early recognition, that baseline knowledge of our risk factors, protective factors, what might be some signs and symptoms that indicate to a nurse, I should maybe explore that a little bit further, and then engage in that nursing process of assessment, formulating some nursing diagnoses, doing that planning, implementation, right? Collaborating with the client and coming up with a care plan, and then that ongoing evaluation. So we have this kind of an overview of what that looks like, but also we have more detailed nursing care plans focusing on some of the most common perinatal mental health issues. Not only does it take a look at that, but it will help nurses kind of determine what are some signs and symptoms that might indicate that this client is in crisis and require emergency interventions. So as we take a look at these resources, you'll find that both the care pathway as well as the guidance document that comes along with it, and we're also working at some other resources to help nurses in the field, is it kind of provides a little bit of that structure to home visiting in terms of identifying, assessing mental health concerns in the perinatal period, identifying, are they at low, moderate, severe risk? Are they at risk for crisis? Are they in maybe crisis? Do they require just some, ongoing support? How do we collaborate with the client to develop a plan, maybe focus on some of those secondary symptoms, as well as, how do we facilitate access to some of those community-based supports, including primary care? But what are some of the best practices that we know that are available? Quite many of them we're already using today, but how do we continue to build upon some of those best practices in our home visiting practice? So here is a little sneak peek at what the overview framework will look like. So I just want to highlight a couple things to you as we go through this. I know the font is small, but up here really, again, draws attention to that recognition first. So, developing that baseline knowledge, that confidence, that skill set to recognize signs, risk factors, protective factors for perinatal mental health, including suicide ideation. We also want to recognize our nursing clinical judgment. And regardless of where clients are scoring, right, our nursing clinical judgment really kind of takes precedence over how we're going to support this individual. you'll notice that it's kind of broken down by different perinatal mental health categories, right? So we focus on some of the more common ones, more prevalent within that perinatal period, being perinatal anxiety, prenatal or postpartum depression. There is some risk for suicide during this transition in life moments. And we also want to be aware, even though prevalence may be low, nurses within home visitation are in a unique position to recognize potential psychosis or homicidal ideation. As you can see, then, it walks through this nursing process for how do we assess. And we'll talk a little bit more about these in detail. But how do we assess, right? What are some open-ended questions we can use? What are we looking for in terms of the client and how they present themselves or their home environment? What are some formal tools we may use? What might be our nursing diagnoses? Determine whether or not they're not in crisis or they are within crisis. What does that planning look like based on that assessment? What might implementation look like? And what is our evaluation going to be? So underpinning all of this incredible work, we really want to emphasize, and Bonnie and I are going to take a look at these in greater detail, is really aligning our work with the nursing process. We wanted to kind of capitalize on what are you already doing within your practice already in terms of home visiting nursing care, and really empower that clinical nursing judgment, recognizing that sometimes things are not quite linear. Sometimes they're iterative and cyclical or a little bit of a roller coaster, right? We're taking in so much objective and subjective information that our clients are sharing with us, right? How do we translate that into a nursing care plan? How can we focus ultimately on the client's parenting goals and kind of reduce some of those mental health symptoms that they might be experiencing so that they can have the strength and the energy and the capacities to work on some of those parenting goal pieces. How do we support nurses to identify, assess, and provide interventions to families experiencing maybe a poorer mental health, leveraging those community resources and evidence-based and evidence-informed nursing strategies, and just simply recognizing that perinatal mental health is complex. Sometimes we want people to fit really nicely in these little boxes, and they don't. We're dealing with dyads and triads and families and mental health existing along a continuum, right? So it's very complex, and we want to recognize that. And again, that kind of goes back to that second bullet of empowering that clinical nursing judgment. So let's look at these in a little bit more detail. Although I presented the framework to kind of look rather linear, we know that it really isn't, right? It can be a little bit more circular, as we see here, with that nurse-client therapeutic relationship in the middle, but it can be a lot more iterative. For example, you can be working on identifying goals while subsequently, exploring strategies to address symptoms. They might share something while you're collaborating on implementation that adds to your assessment pieces. So sometimes things will happen very fluid, very logically in a linear sense, but sometimes we're doing multiple components at the same time as nurses within our nursing care. And sometimes this engagement, sometimes this nursing process might not only happen at one encounter. Sometimes it will happen over several weeks or several months, where you're continuously assessing, reevaluating, coming up with new strategies with the client. So we just want to be mindful of that. So the presentation of our frameworks do appear linear, but we recognize that as nursing is a little bit more fluid than that. So recognition. So it is imperative for nurses to have this baseline knowledge to be able to recognize signs, risk factors, protective factors for perinatal mental health concerns. That will include suicidal ideation, potential psychosis, potential homicidal ideation as well. But at every nursing encounter, we have this really unique opportunity to explore a little bit the mental health and well-being of the client. So again, nursing clinical judgment is a key component of this. Upon recognition, that's when we shift to maybe some more formal assessments. Now, there is some literature out there around universal screening. We have taken the approach that we want to fundamentally build it upon nursing clinical judgment, whether to assess or not. There's some ethical considerations with universal screening. In Ontario, we do tend to be a little bit of under-resourced in terms of mental health treatment, programs, services, assessment. There may be long waiting lists within your community. There's barriers to accessing some of those services from a social determinants of health lens. So if we're applying universal screening and there's not immediate assessment and treatment, that leaves us in a bit of an ethical dilemma as nurses. Now, I also recognize that the Nurse Family Partnership Program has some timed components where it's part of their process to assess and to use tools. But in addition to that, they also have or based on clinical nursing judgment. So this early recognition, kind of this first step, is really where we want to explore things with our clients. This is a time to even start thinking, might this client be in crisis or not? So we want to start here. We want to start with this early recognition. And then if it's kind of like, I'm showing up at the house and they're showing up in their robe. It looks like they haven't showered for days. Maybe, the home looks, more chaotic than what it usually is. They have a risk factor of prenatal anxiety, prenatal depression. We're at 4 months now. There's a couple of things that's kind of telling me I need to assess further. So there's some evidence-based tools that you can do. That includes the Edinburgh Postpartum Depression Scale, or EPDS, the Generalized Anxiety Disorder 7, or GAD-7 tool, the Patient Health Questionnaire 9, or PHQ-9, and our Columbia Suicide Risk Assessment, which is here noted as the CSSRS. Now, these are tools that are non-diagnostic for nurses. They help us to determine a level of risk. Might a client be at low, moderate, or severe risk for a mental health concern? But in addition to those tools, there are other things that we can do and explore as nurses, right? What are the client's mental health goals? What are their parenting goals? Do they have any strategies that they've used in the past to help with their mental health or coping? Are they using any strategies now? What's worked for them? What hasn't worked for them? If it hasn't worked for them, why not? Are they using any medications or substances? What are their ideas about maybe some pharmacological intervention? Do they have any underlying concurrent mental health concerns, such as bipolar disorder or borderline personality disorder or something like that? Do they have an existing diagnosis? Do they have any barriers to accessing interventions? And what kind of community supports are available? What have they tried in the past? Again, what's worked for them? What hasn't worked for them in terms of community supports? What does their support system look like? So as a nurse, we're assessing all of these things. Now, again, this might not happen at just one encounter. This might happen over a series of encounters, but we're taking a look at a variety of subjective and objective information when we're doing our assessments. Then we have our nursing diagnoses, right? So this is kind of the basis for what we then determine our interventions to foster optimal client outcomes. So they can be problem focused, or they can be a risk diagnosis or a health promotion diagnosis. But one of the things, again, that we want to then prioritize is this client considered at critical risk? Are they at severe risk for suicide, potential psychosis, acting on thoughts of homicide, right? That can help us then determine that we're going to go down a stream of crisis intervention. Or if maybe they're at low, moderate risk or severe risk without the critical components. Some examples of nursing diagnoses might be that they're at risk for low, moderate, or severe excessive anxiety. Maybe they're at decreased risk for their self-care and their capacity to engage in behaviors that are going to foster mental health well-being. Maybe they have an ineffective sleep behavior. So what does that look like? What's getting in the way of this client having effective sleep, which can be really challenging to assess in that immediate postpartum period when that little baby needs to eat every 2 to 3 hours. Or are they at risk for suicidal self-injurious behavior? That's that critical risk piece that we were talking about. So within your documents that you'll be receiving, there's going to be an example of several nursing diagnoses to kind of draw from. A lot of them are taking a look at the symptoms that clients might be experiencing if they're struggling with mental health concerns. It is not an exhaustive list, but at least it's a place to get started. So planning. So this is when we're going to prioritize kind of those nursing diagnoses and determine what some of those interventions are going to be. Again, placing more critical importance for clients that may be in crisis. But nursing plans, we want to consider like a lot of validation and normalizing of clients' thoughts, their feelings, their experiences. Maybe we're going to do some health teaching and some skill building regarding some mental health concerns, and referral considerations, right, to those healthcare providers, particularly for those that are more moderate to severe risk. So implementation, what are we going to do? Within that therapeutic relationship, we're going to collaborate with our client, offer very client-centered care, focusing on what are their goals, what are the things that they want to work on for their mental health wellness, what's getting in the way of them achieving, again, some of their parenting goals and having that maybe be part of the care plan. So validating and normalizing their experiences, their emotions, maybe even their thoughts, right? Providing health teaching and skill building. We excel at this as nurses. There are a variety of strategies that you already are implementing within your practice. What you'll find with that guidance document and the care pathways is a lot of those strategies that you're doing are reflected within that work. What we've just kind of taken is what are the best practices that we know that have the greatest impact, and maybe highlighted a couple of them for you. So you might be very validated looking at this document and be like, okay, keep doing the great and amazing work that I'm doing. But also you might see some things that's like, oh, I've never really quite done that with a client before. Maybe I'll try that out and see how that goes. Of course, completing warm or formal referrals to some of the mental health supports that exist within your community, connecting them with their primary care provider if they have one, and explore their readiness for engaging in some of these practices and behaviors. We want to take a look, are there barriers to care? Are there social determinants of health considerations? Are there cultural considerations that we need to consider? And again, we're always collaborating with the client on next steps and those action items and coordinating any follow-up. And then evaluate. Evaluation is always ongoing, right? Are the interventions working? Are they not working? How can we identify any barriers to carrying out the interventions? Or do we need to shift to something else? Maybe we need to repeat the GAD7, EPDS, PHQ9, or CSSRS, right, based on our clinical judgment or our locum program procedures. And then, as always, really important for us to engage in that reflective practice and clinical supervision. Vicarious trauma is very real when we're working with clients with mental health concerns. That can have an impact on us as nurses. So how are we feeling after that encounter? What are our thoughts? Gibbs reflective practice cycle is something that we use within our organization to kind of unpack some of those thoughts and feelings in caring for our clients. I'll just pass it over to Bonnie now to kind of talk about some of those other underpinnings.
So one of the most important things, and I think Christina has touched on it with the nursing care plans, is that we wanted them to be developed in a way that really empowers and recognizes nursing judgment. So having the flexibility to be client-centered, to be responsive to individual client needs, preferences, and family circumstances. So they're not prescriptive, they are flexible. It allows the nurses, as they develop that therapeutic relationship and get to know the family, to really tailor the care plan to be the best fit for that family possible. The other thing that's really important too, as we get into some of the potential nursing interventions, as well as Christina described, some of the tools for screening and assessment, is that there's opportunity to embed local health unit policies and procedures where appropriate. So for example, most health units have a specific policy and procedure around clients at risk for suicide or psychoses or homicidal action. So we felt it was really important to make sure that the individual policies and procedures for local health units could be embedded into the care plan so that it's consistent and congruent and not in conflict. And another really important underlying principle was that the care plans support PHNs through identification and assessment, as well as providing intervention for families experiencing poor mental health. So Christina did a really great job walking through the nursing process. And the nursing care plans are built on familiar tools that are evidence-based. And the 4 are listed there, but they're not new. We didn't want to bring something completely new into the picture. We really wanted to build on the tools that nurses were already familiar with, they've already had training on and already comfortable using in their home visiting roles. The 4th underlying principle was that the care plans really leverage community resources and evidence-informed nursing strategies. So we looked at the evidence-based practices already part of the Healthy Babies, Healthy Children and Nurse Family Partnership Services. So PMMHDP, so the promoting mental health, maternal mental health during pregnancy, the partners in parenting education strategies. NESTS is another common one. And we also looked at and considered the emerging best practices. So a lot of work is happening across the province and a lot of interest in psychotherapeutic techniques, as well as safety planning. And again, some of those would be dependent on individual public health unit policies, procedures, nursing practices, and resources. And then the last underlying point, which we've touched on already, is just how complex the issue of perinatal mental health can be. And we recognize that there's intersection with some more common issues like birth trauma, intimate partner violence, maternal mental health in fathers, challenges in working with multicultural families, as well as challenges of supporting individuals with health behavior change. It's a very complex issue, so we wanted to not make the care pathways more complicated, but look for opportunities to include those topics in the resource document, the guidance document that will accompany the care pathways. So this is a sneak peek at the table of contents overview for the guidance document. So there's an introduction to the work that's been done and to the resources that are available. There's a pretty comprehensive description of mental health concerns in the perinatal period. We thought it was really important to include a section on adjustment or transient mental health concerns. So what would be considered normal adaptation to pregnancy and parenting, description of baby blues, what does that look like? And then it segues into early recognition of mental illness in the perinatal period. There's a significant emphasis on applying the nursing process to perinatal mental health. So the overview that Christina provided and the description of the nursing process is outlined in more detail in the guidance document. There's a significant section on anxiety and related disorders, and including information around the PHN care plan and how to apply it. The same for perinatal depression and symptoms associated with depression, and sample care plans for supporting clients at risk for depression. There's a section on suicide risk, including the PHN care plan, and also psychosis and homicidal ideation. So each one of the nursing care plans that you're going to see has a corresponding section in the guidance document that provides additional information and support in terms of how to use the care plan. And then there's a section at the end called Other Considerations, and this is where we kind of lumped in some of the factors that really can make mental health more complex in this population. And there's lots of resources and information included there. There's a section around supporting clients with bipolar disorders, the impact on birth trauma, supporting clients with trauma and violence-informed care, the impact of intimate partner violence on perinatal mental health. There's a great section on reflective practice and clinical supervision, the social determinants of health and how that can impact on maternal health, and working with clients who are hesitant to engage in behavior change. And then a big reference section at the end. So this is just a sneak peek of the guidance document that will be released soon, but it gives you a sense of how extensive it is as a resource document for nurses. Okay, and Christine, I'm going to turn it back to you to walk through the individual care plans.
Thanks, Bonnie. So this is an example of what the anxiety plan may look like. So again, early recognition to start based on clinical judgment always takes precedence over all these other areas. So using your open-ended questions, maybe using a tool like the GID-7, is your client at low, moderate, or severe risk? So taking into consideration all of that subjective and objective information that you have available. Utilizing those tools, utilizing those open-ended questions, right? Determining what their risk level may be. Then shifting towards a nursing diagnosis, right? Are they at low, moderate, or severe risk, for example, of generalized anxiety? What might your nursing plan look like? And implementation. So again, really drawing on what are some of the best practices that exist already out there, utilizing the Promoting Maternal Mental Health During Pregnancy resource, maybe even some psychotherapeutic techniques with clients. And again, if they're at severe risk or even for those at moderate risk, helping to make those connections with a healthcare provider to receive additional assessment and treatment. So some of the things that we help to tease out are like, what are some of the things most helpful with an anxious individual? So maybe that might be taking a look at their sleep patterns. It might be prioritizing relaxation strategies, things like that, and drawing from the various resources that we already have available. And then evaluation, right? Like, how do we continue to check in with the client and evaluate how things are going? This is an example of what the depression one may look like. So again, nursing clinical judgment, recognizing signs, risk factors, protective factors, using those open-ended questions, using an EPDS or PHQ-9. So EPDS is validated in the postpartum period, so birth to 12 months. I know that some practitioners will use it in the prenatal period. Some will use it up to 18 months postpartum. The EPDS has various statements that focus both on anxious components and depressive components of perinatal depression. The PHQ-9 is validated for those that are ages 12 and older, can be used at any given time, regardless of whether they're in the perinatal period or not. So we just wanted to highlight that both of those tools are available to enhance your assessment if needed. If you're using either the EPDS or the PHQ-9, there are questions, so question 10 on the EPDS and question 9 on the PHQ-9, that do ask about self-harm. So any kind of a positive response to that, it's kind of our obligation then of nurses to explore that a little bit further. So you'll see that kind of component in there that you would shift to a suicide risk assessment and follow your local policies and procedures regarding that. Because then you might have to shift to a more like crisis intervention if there's thoughts and a plan and intentions to act on a plan of suicide and or homicide. So I know within our practice, even at Niagara, if using the EPDS, after we ask the question, have you had any thoughts of harming yourself, right? And you have those options that you present to them. We may also ask them, what about thoughts of harming someone else or your child? Just to enter into that other line of questioning a little more gently. Formulating that nursing, diagnosis, right? So is it related to sleep? Is it related to, disorganized thoughts? What might be some of those nursing diagnoses? Planning for that, right? So we're going to validate, normalize, maybe do some health teaching, connect them with different supports depending on severity. And again, what are those implementation pieces? So with depression, it might be more focused on some of the self-care in terms of behavioral activation. We might be taking a look more at, their eating and nutrition kind of routines, their sleep hygiene, their community supports, right? What does their support system look like in terms of social information, emotional support, practical support? So kind of exploring those domains of support with the client. And then do we need to have any referrals or make connections to primary care for additional assessment and treatment and ongoing evaluation with that? This is an example of what maybe a suicide care pathway may look like. Clinical judgment, again, very, very prevalent in this because you're looking at a variety of things when reducing the risk for acting on suicide in the moment. Different training options that might be available for your local health unit, assist training, mental health first aid, safe talk. A lot of them will address some kind of prevention in suicide, how to have conversations, how to ask about it. The CCSSRS has online training videos on how to use that as a tool and how to engage conversations with clients about suicide. Are they at low, moderate, or severe risk? If they're at severe risk with immediate intent to harm, right, that's a crisis, that's an emergency, engage with in 911. If it's maybe not as life-threatening, we still want to engage them with some immediate supports. Low and moderate risk, right? We might still be looking at developing some coping plans with the client as we work throughout the nursing process. So again, there's some strategies here depending on their risk level. within the guidance document, there's a lot of language about like thoughts, right? And just because we have a thought, that doesn't mean that we're necessarily going to act on that thought. I might be going grocery shopping and I was like, oh, those chips look really good. That doesn't mean that I'm going to buy those bags of chips. It just means those chips look really good, right? So distinguishing between some of those things. When an individual is experiencing maybe perinatal depression, right? Some of their thoughts might be around self-harm. Some of those thoughts might be around harming a child. So really developing our confidence and our skill set and our assessment skills in determining, is this just a fleeting thought for an individual that evokes a lot of shame and guilt and fear, or is it thoughts that a client might plan on acting on? And do they have a plan in place? Are they going to act on it anytime soon, right? So some of these additional training and resources can help build nursing confidence in having these conversations and responding to what clients are saying to us within that home visiting environment. Perinatal psychosis, right? So this is a psychiatric emergency that can occur within the postpartum period. And again, as home visiting nurses, we're in a unique position to identify this. So we do have a care pathway that's available for you to determine may or they may not be at risk, and how do we engage an emergency response system for that. Some things that have even come up in literature, right? Like some people are not willing to access emergency services because they're worried about their children, they're worried about their pets, and will decline services. So again, how do we decrease those barriers? How do we protect our safety? How do we protect the safety of the children? How do we protect the safety of the client? And homicidal ideation being one of them as well. So maybe again, lower in prevalence, but again, could be a potential if a person is experiencing psychosis or is at risk for psychosis. So we wanted to make sure that some tools were available for nurses to kind of refer to if they are ever faced within that context or that situation with a client. Again, following that nursing process of recognizing, assessing, diagnosing, planning, implementation, and evaluation. And back to Bonnie.
Thanks, Christina. So we just had a couple other things that we wanted to mention briefly during the webinar. So because the nursing care plans were developed specifically for healthy babies, healthy children, and nurse-family partnership PHNs in the home visiting role, we felt it was really important that there was good alignment between the nursing care plans and the family service plans that are used in ISCUS. And you'll see the 4 bullet points here that just reference the healthy attachment, optimal growth and development, optimal parental health, and optimal prenatal health, and then the statements that would apply to the client scenario. So there is good alignment between the nursing care plans and the family service plans in ISCUS. We didn't want them to be conflictual or not in alignment. So you can see the four areas there that are relevant. And the other thing we just wanted to do was give a shout out to the Ontario PHN Mental Health Community of Practice for Home Visiting Work Group that's already in existence. And so the purpose of that group is really looking at building competence, including knowledge and skill and judgment with the PHNs who are currently providing home visiting and delivering psychotherapeutic-based techniques with prenatal clients and with clients with young children. And so there is an opportunity for 1 or 2 representatives per each health unit who've had training in delivering these techniques within the home visiting setting. And if anyone is not yet connected or is interested in getting connected, Tammy Thompson is your resource, and her email has been included there for reference. So we're nearing the end. So next steps, where are we now and where are we going? So today was about introducing the work that's been done, the underlying principles and assumptions behind the development work, the tools that are coming out. So you've been introduced to the framework. Christina's given you a sneak peek to the care plans that are coming, and you've seen the content that's coming in the guidance document. We anticipate that all of these should be released to health units by the end of November fingers crossed, or November 29th of this year. So they're coming soon. And we're looking at additional training and practice resources to be released in 2025. And then in terms of where we're going, so PHN Prep continues to be committed to working on an ongoing program of professional development, using strategies such as the webinars, developing some really neat educational resources that we believe will enhance and reinforce nursing knowledge and nursing skills. And those will be coming out over the next year. And there's some exciting upcoming PHN Prep webinars. I think the next one is early December. And that's going to be a deeper dive into each of the care plans. So stay tuned for more information about the upcoming webinars. And now I'm going to turn it back over to Susan, who's going to take a look at all of the questions that have been entered into the chat.
Great. Thank you, Bonnie. Thank you, Christina. This has been such an immense body of work, and the leadership that both of you have provided, as well as the labor and sweat to create these is so greatly appreciated. And I, for one, am just really excited about the nursing focus of this work, and really the opportunity for nurses to work at their full scope and to reflect on the knowledge and skills that all of you have that can be applied to support optimal mental health with the clients that you serve. So the questions have been coming into the Q&A, and so I'm really excited to start to ask these to you. So I think, Christina, in the guidance document, will there be any information or appendices about processes around supporting recognition or response to perinatal OCD or bipolar disorder?
Oh yeah, we really recognize that there are a lot of mental health concerns that can occur within the perinatal period, outside of the perinatal period. A lot of our home visiting programs, we support clients prenatally, nurse family partnership up to 2 years old, healthy babies, healthy children up to entering into school. That can cover a huge range of mental health concerns. And unfortunately, the project was very time limited, where we had to focus on what were some of the more prevalent things. So bipolar disorder, I believe, is touched on very briefly, but we made a very conscious decision not to include borderline. As we explored borderline personality disorder, even though, again, quite high in prevalence, regardless of whether or not they're in the perinatal period, what we're hearing from practitioners is that they do encounter clients with borderline personality, but we had to stop working out the document at some point. So it is flagged. PHN Prep is very aware that that is an ongoing need, an ongoing resource that might be required within home visitation. But just for the sake of meeting our project timelines and requirements and funding requirements, we did not address borderline. But who knows? Finger crossed, stay tuned. It's definitely something I personally would like to sink my teeth into a little bit more in terms of supporting nurses and how to navigate some of that within the home visiting context.
Great. Thanks for summarizing that, Christina. And Christina, I'm going to ask you this one as well, because I know it's a question that aligns with conversations that we've had, and I've learned a lot from you about normalizing some healthy responses during some of these complex transitions. So the question is there a risk in normalizing client experiences if they are actually not healthy, but seem to be socially normal to the client, given the increasing incidence of perinatal mental health services? Would normalizing it create less incentive or urgency for the client to receive support?
I think it's like what we are normalizing, right? So if I have a client that's sharing with me that they're feeling overwhelmed and anxious and are having trouble sleeping, I may then choose to normalize. I've heard other families that I support share that adjusting to parenthood can be very overwhelming. And then when you're not sleeping well on top of that, sometimes it can be really challenging to cope with now bringing a baby home. So I think it depends on, so what we're kind of normalizing is very specific thoughts or feelings. So sometimes postpartum depression exhibits as anger, rage, feeling irate. And they'll say things with you that might be, I'm never like, I never have this kind of a temper. I'm never this short with my partner. Like the littlest things that they do set me off, and that's not like me. So then, saying that and rephrasing that and turning it around to share, like, there's other families that I know that experience something similar after having a baby, that there's changes to their temperament, that they become very short with their partners, they're quick to anger, and that doesn't seem like them. Is it okay if I ask you a little bit more about that? So it's more kind of normalizing that other people that experience mental health concerns might also struggle with some of those similar behaviors, feelings, or thoughts. So you're not necessarily normalizing the experience, but equating that with, I know other families might struggle with something that you're struggling. I hope that helps to answer that question. I don't know if anybody else would like to add to that.
Yeah, Bonnie, and anything else to add? Oh, you're on mute.
I don't think so. I think Christina did a nice job of providing examples of how, asking questions to really delve a bit deeper into what the clients are telling you is important. So no, I don't think I have anything else to say.
Great, thank you. So the next question, I think, what in nursing, when we have assessment tools like the EPDS or the General Anxiety Disorder 7, one of the opportunities when we ask those questions is that we're getting information around specific secondary symptoms, and that then gives us opportunities to know where are some priority concerns for the client. So I think, always us as nurses remembering that we're not just asking these questions to get a score, that there's also some additional information. So, in alignment with that, and I'm just looking at the next question, could one of you do a brief review of what are examples of secondary symptoms of postpartum depression and examples of secondary symptoms of anxiety? And again, knowing that that's within a scope of nursing practice to address secondary symptoms.
You want me to go first, Bonnie?
Sure.
Okay. So with depression, some of the things that we might be recognizing as some of those secondary symptoms are withdrawal and isolating, right? So they might not be connecting with family and friends. They might not be attending early on centers, right? They might have a tendency to stay at home. So as you're working through your nursing process, part of that plan may be to engage some of those support systems and maybe the socializing aspect of supports. When we're depressed, sometimes our engagement and self-care goes down. And when I speak of self-care, I speak of doing activities that give you a sense of accomplishment, or doing activities that bring you joy and make you feel happy, right? So if we're noticing that component of self-care where they're just going through the bare minimum of activities to get through the day, so how can we bring in some activities that bring a smile to your face? How do we engage in that? Sleep has both an impact on anxiety and depression, right? So ineffective sleep routine. So with anxiety, that might be, an older child where the baby's finally down, they have a little bit more of a longer period of time of rest, but the client's thoughts are keeping them up at night. So thoughts about themselves, their relationships, the future health and well-being of the baby. They're constantly checking in, right, on the child. So, it's the racing thoughts that are keeping them up, not the fact that the baby has to eat so often. So what are some strategies that we can use to, engage in relaxation strategies? Do we need to maybe apply something like a thought record, which is a concept from CBT or cognitive behavioral therapy? So what are some things that we can do then to support the client with some of those symptoms that they're presenting with? And that comes from the conversation that we have with the client.
Great. Bonnie, anything else to add? No. Okay.
Sorry, I keep hitting my mute button. I was just going to say it can be something as simple as lack of good nutrition. I think sleep is a big one. Loneliness, isolation, lack of social support. So I think Christina touched on all of those.
Okay, great. Thank you. And as I scroll through the list of questions, I see several questions that are really in alignment around, again, when are the plans available? Wondering what the next steps will be for finalizing the materials, continuing to hear that the care plans may look like this. When will we get the products? So I'm gonna answer that one. And Bonnie, you had such a great slide that summarized some of that. It is our goal through PHN Prep to circulate the care plans. And yes, they said draft, but the care plans are in their final form, probably 99% by the end of November. And we have a small but mighty team that is dedicating a few hours a week to this work. So acknowledging Christina Bradley's leadership and Sonia Strom and Jessica Weatherby with PHN Prep, who are finalizing all of these resources. And right now our time and attention is focused on the guidance document. And I think the last check last weekend when I looked at it, it's about 86 to 90 pages. And we're looking for ways to ensure that this document is not just a PDF that we send to you, that it is user-friendly and is accessible on your devices with some hot links to go to resources. And we are not IT people, but we're doing our best to use technology. So right now we're just finalizing that guidance document. We've had different people review it. So it is in the plan that by the end of November, all of those care plans that you've seen, as well as the guidance document, are disseminated to all 34 health teams to have and to share and to reflect and to use within their teams. And then on December 4th, we won't have a webinar in November, but on December 4th, once you all already have these resources, Christina Bradley will come back for our webinar on December 4th and really do a deep dive in reflecting on what this nursing practice looks like on some of those very specific nursing care plans. So that's our plan for rollout for this year, and the ongoing educational resources to support continued professional development in terms of e-learning modules and webinars. We will continue to roll those out. And as Bonnie and Christina also identified, we recognize that training is just one strategy to increase knowledge, skills, and confidence. And that's why we're also looking at different ways to support different communities of practice so that nurses and supervisors have ongoing opportunities to work with peers to ask questions and to continue to develop these skills. So we're, slowly but surely everything will be coming out. So I hope that's answered a lot of those questions around timing. Okay, so back to some of the other questions. Christina, we use the EPDS along with clinical judgment as a guide to accept clients into the Steps to Wellness program. For example, client inclusion criteria is a score between 10 and 23. Is there any guidance around the GAD-7 or PHQ-9? For example, when would a group CBT be helpful to the client?
I think that depends on what your inclusion criteria is for your particular agency, right? So Niagara's was just based on, conversations that we had as being part of the randomized controlled trials with Dr. Ryan Van Lieshout. What were some of their inclusion criteria at the time? So we landed on the EPDS. I don't think there's anything prohibitive of using the PHQ-9 or G87s, but in terms of what those cutoffs are, I think that would be a conversation to have with your local health unit. I would probably engage Dr. Ryan Van Lieshout on that, who has much more clinical experience in utilization of various tools for inclusion into practice compared to into research study projects. We know that there's a variety of tools that can be used to determine whether or not clients are at risk. The Steps to Wellness program is, designed to support clients that do have a level of risk, whether moderate to severe, but also to have certain cutoffs to rule out individuals that have concurrent mental health concerns that might be outside the scope of that particular group. So I think those are just individual health conversations to have within your health unit.
Great, thanks, Christina. Okay, here's another question, and maybe I'll ask you this one, Bonnie. Wondering if perinatal mental health is the first topic where nursing care plans have been developed for home visiting practice, or if there are other areas where other public health units are using nursing care plans for home visiting.
That's a great question. To my knowledge, I mean, this is the first initiative that I've been part of that really has adopted the nursing process as the framework and care plans to go with it. But I'm sure there probably are other health units that have spent time developing care plans on a variety of issues. I mean, certainly the family service plans are helpful in terms of care pathways. And maybe some nursing interventions, but I think it's a great question to ask of the ministry, because it would be super exciting to see this model applied to a whole bunch of other issues and topics that are faced by families that are receiving home visiting services, like attachment, like healthy growth and development, family well-being. So yes, it's a great question, and I think it's a great question to put forward to the ministry.
Yeah, no, it is a great question. I don't know if people in the chat, if your health unit is, even pop something in the chat for everyone. I'm really proud to be a nurse. And I think when we look across the landscape of all of the different colleagues and healthcare professionals who provide mental health counseling and support to individuals, that as nurses, we do have something unique to add. And by framing this work within the nursing process, I think it gives us confidence and validation and language that this is nursing work and that this is what it looks like when delivered by nursing. Where's our area that we can focus on from nursing? And thank you to Christina for the time invested in reviewing nursing diagnoses. For many of us, maybe it's way back from our BSCN degrees where we thought about some of the NANDA nursing diagnoses. And I have so many mentors in public health, and I've really been inspired and encouraged by Susan Potvin, who's an HBHC manager in KFLNA in Kingston. And I know on their team that nurses get the nursing diagnoses handbook to really think about what is the focus of nursing work. And around perinatal mental health, and Christina has already talked about this. Part of our role is in identifying those secondary symptoms, the physical symptoms, the isolation, the sleep disturbances, changes in appetite, some of those even feelings of guilt or worthlessness, and then identifying interventions to address those secondary symptoms. So I think this framework, we really hope that it allows everyone to reflect on what is the nursing work here. Okay, scrolling through, there's so many great questions. Will there be space in the care plans to add local mental health resources to adapt the tools to support referral pathways for moderate to high-risk clients? Christina, I know that you jam so much into those resources, and people will be able to print them big or small. What are your thoughts on health units adapting and having space? I think they're developed in Visio. Is that accurate?
They're absolutely adaptable, right? Like our goal was just to provide a framework, a place to start for health units. For example, within Niagara, when you look at we're updating our suicide care pathway to kind of reflect this nursing process. But in it, we have our local numbers. So we have our mobile crisis numbers, we have our distress numbers added to the implementation section. So we encourage you to adapt them. We encourage you to, modify them in a way that meets with your local policies and procedures. In Niagara, we do have an overarching policy on promoting mental health with clients. And under that, we have procedures for using all of these different assessment tools. And what does that look like? And who can you use them with and when, right? So we do have that in terms of building that support. But our care plans will reflect our local resources and numbers, and referring to, our Steps to Wellness program, and those kinds of components will be embedded into it. So this is just kind of a place for health units to get started. And we encourage you to, if you choose to adapt any of these, to have it fit within your local context.
Great, and thanks, Christina. And we will, this work is funded and supported by MCCSS, so we will make the resources available. I think other health units, you'll need to have access to Visio to make the edits, but it makes sense that, to be able to tailor and add those local resources, because then it becomes an even, I think, more useful tool for nurses in practice if you have it tucked in your bag or your box, whatever you have in your car, that you can pull out and have those local resources. So when health units get to that point of tailoring, please let us know, and we can share the files and formats that make sense for you to adapt. Well, the next question, I'm not sure any of us will know the answer to, but will the GAD-7 be added to ISCUS? Bonnie?
I don't think any of us have the answer to that, but it's certainly something that we can ask for.
Yeah.
I know that our data analyst for Niagara has, created forms that are available to enter that information into ISCUS. So it is possible. It just requires some work on the back end and a level of transcription on behalf of the nurse to take that information and put it into ISCUS.
Okay, so we know it's possible. It takes skills and resources. And Bonnie, as you've identified, in our next communication to our contacts in the ministry, that certainly can be an ask that we can put forward to let them know that there is a need from the field, share the nursing care plans and the frameworks with them so that they're also aware of the type of data that's being collected. So
for Niagara, yeah, sorry, Susan, go ahead.
No, go ahead, I'm done, yep.
In Niagara, because we use the Columbia as our suicide risk assessment tool, they have a short and a long version. So both the short and long version have been integrated into ISCUS for our staff.
Okay, great, thanks, Christina. In my experience, Niagara Public Health and Emergency Services is a great source of information and has been such a leader across the province. And I often, in the circles I work with in public health, I often say, why are we all shouldn't be reinventing the wheels. And so we hope to create these structures also where people become aware of other health units that have done some of this work, and how do we share and partner and learn from each, how do we, learn from each other. Okay, and so I see another comment there. Can we please advocate with MCCSS for these pieces to be referenced in any updated version of the HBHC guidance document? Absolutely. We share our resources. They approve our deliverable plans every year, so they're aware of what we're doing. And I'm taking a photo of that right now so that when we do have our meetings with the ministry, these are points that we can raise. And I encourage all of you as well that when you meet with the regional partners now, or the regional hubs, that these are also questions that you raise up and ask for, so that there's this groundswell at the grassroots of identifying that across health units that there's some value to having also some provincial overview or even the potential for some updated guidance documents. Okay, the EPDS is available. We have time for just a couple more questions. The EPDS is available in translated versions, but I would like to know where to find the updated, translated, validated versions. Also, are the GAD-7 and PHQ-9 available in different languages?
I don't know the references off the top of my head, but they are included in the guidance document.
Yeah, excellent. So
Yeah.
yes, thanks. We will have a link to the updated, validated, translated ones we've tried to pack as much information into that guidance document. So we can check mark that that's one of the things that we did provide. Can you explain how to include NCAST and PIPE with these care plans and with delivery at home visits? Bonnie or Christina?
You say the question again?
Yeah, any thoughts around how to integrate this care plan with some of the NCAST or PIPE materials in a home visit?
I think some of that has already been included in terms of nursing interventions, but I think it'd be nice alignment, right? So if a client has a care plan specific to postpartum depression, she may also have a goal around attachment. And so I think the interventions of PIPE and NCAST would be included under the attachment goal, but I mean, they're all interconnected. So while we didn't include a lot of that in the mental health care plan pieces, I think there's a nice intersection because the concern around attachment is directly correlated with maternal mental health. So I think you would probably still have to have a secondary care plan specific to healthy attachment, but you could certainly reference the strategies that you're using around promoting maternal mental health.
Great, super. Thank you. And you referenced this when you all see the care plans, and you may have seen in the draft as well as what Bonnie alluded to, is that NCAST is from the Parent-Child Relationship Program at the Bernard Center at the University of Washington. And as many of you are aware, they also have developed and support the uptake and implementation of I always get it wrong, but the Promoting Maternal Mental Health During Pregnancy
Correct.
program. And so again, the working group and Christina has carefully gone through those materials and specifically identified from those resources which chapters or units would be most useful or relevant for nurses to use depending on the client's level of risk for depression or anxiety. So we've done some of that tailoring work specific to those parent-child relationship program materials. And we've also had support. Anya Cahill has been working with the NCAS PCI instructors and health units to ensure that there are at least some nurses trained and having opportunities to be trained in the updated program materials to become champions to train back to their health units. So we're trying in different ways to promote that capacity with very few resources for all the health units. And I see one last question around sleep and baby sleep and the connection to perinatal mental health. And just to highlight again that Anya Cahill, who is the provincial nursing practice lead, who works alongside the NCAS PCI instructors, that their working group is right now working on a whole revised set of resources around infant sleep. So again, those packages will be rolled out, and what that will be a focused area of one of our webinars in the new year is again that focus on parent-infant sleep. Okay, and then with the last question, will a similar care plan format eventually be available regarding intimate partner violence? Okay, great question, and it gives me something certainly to consider. I think there may be some value to that. I've certainly added a section to the guidance document in thinking about specific concerns related to intimate partner violence and mental health. It is part of good standard practice that if individuals recognize depression, anxiety, or PTSD amongst clients, that those are risk indicators, those mental health conditions are risk indicators to ask about intimate partner violence. And the reverse is true, that if individuals share with you that they're experiencing intimate partner violence, that exposure or experience, we are known, increases the risk for depression, anxiety, and PTSD. So those two conditions are so tightly interwoven that we need to think about them not in silos but in together. So we have started some of that work. So that gets us to the end today, and I know there's still some additional questions, but I'm so sorry we didn't get to all of them. But as always, thank you so much for everyone's engagement. We're so excited that hundreds of you come every month, and we're really excited to share these resources. Thank you to Bonnie and Christina for presenting. Again, on December 4th, Christina is going to return, and we're going to start the deep dive into the nursing care plans. And as always, thank you to Andrea Bodkin for co-moderating with me, and the incredible support that Public Health Ontario provides in giving us this venue. So thank you to everyone, and wishing you a good rest of the day.